We will move to the next. Thank you. So the next talk is Invasive Fungal Disease in Hematology Patient, New Frontier. This is a Gilead satellite talk. It will be given by Dr. Varun Mehra. Dr. Varun Mehra is a hematologist practicing in King's College, London, UK. He has an interest in infection and immunocompromise, as well as graft versus host disease. So, Dr. Varun, the floor is yours.
Thank you, Dr. Alfra. Thank you for inviting me over to speak on this topic today, and thank you to Gilead for inviting me to be a speaker on this forum. I'll share my screen. Let me know if there is any issues. Oops, it seems like.
So if you
go
ahead, Prof. Varun.
Yeah, is it all ready? Yeah.
Yes.
Okay, very good. Sorry, it seems like it's a bit out of proportion here, the slides. So no, thank you once again. So yes, I work at King's College Hospital. I'm a consultant hematologist with special interest in myeloid malignancies and stem cell transplantation, but my research interest is in invasive fungal disease in immunocompromised host. And I would like to talk to you about the new updates as well as challenges we face in terms of managing these invasive fungal disease in our group of patients in hematology. This is my disclaimer, sponsored by Gilead, so thank you for inviting me over. And these are my disclosures for my involvement with the industry partners in different roles. And this is where I work. Just a quick summary: that we one of the largest academic health centers in the UK and largest healthcare provider, and have a multiple number of sister hospitals attached as part of our King's Health Partners initiative, in which we have guys in St. Thomas's Hospital, ourselves, St. Maudsley Hospital, and King's College London University, all making the biggest academic health service center in the UK. And in our department, we're a large department with a large consultant pool with 56 adult inpatient beds, and we do around 280 transplants a year. We are the largest CAR T center in Europe, doing at least 150 CAR Ts in the last 3 years. The reason, obviously, I'm here is to try and just have a discussion around why fungus is becoming increasingly a challenge rather than something that we all are familiar with and able to treat. It's mainly because it's just increasingly being identified as a difficult infection to treat, and mainly because we're now having much more access to novel immunobiological therapies. We have increased number of patient cohorts who are now becoming eligible for these immunobiological therapies, which poses new risk for developing fungal disease. We also are running out of treatment options because they are becoming more and more resistant with time, especially with azole resistance becoming a bit more widespread. And that brings a huge challenge for how we will manage this so-called explosion of potential invasive fungal disease and opportunistic infections in our patients. Just to remind the people about how fungi is classified. So we have molds, yeast, dimorphic fungi, but within the hem-onc settings, we normally see Fusarium as an Aspergillus infection as separate fungi, more commonly Aspergillus infection in our hemato-oncology patients, and less commonly Mucor infections. We do see fair share of Candida infections, mainly in line infections, biofilm type infections, or post-surgical infections in ICU, for example. But Aspergillus infection is what I will be focusing on in the rest of my talk. And why, again, it is important, because clearly there are lots of fungus spores all around us in the environment. They all come onto our epithelial surfaces and sometimes can give you nail, skin infections, and may not necessarily make you ill with that. But when you're immunocompromised, and these spores then tend to get through the alveolar epithelial cells and then start germinating, making hyphae and breaking through the epithelial barriers, and also then disseminating through the endothelial barrier junctions, leading to dissemination phase. And that angioinvasion property of these fungal infections, especially Aspergillus, for example, here, can be quite lethal or lead to high morbidity and mortality to these patients. And any steps that are being done to try and identify the infection at an earlier phase of their infection in human host, it will be the key to try and reduce further mortality and morbidity of these patients, and there's a huge amount of work being done to try and reduce this to happen in the first place, or if possible, have an early diagnosis done for these invasive infections. And then again, as I mentioned, our risk paradigm is changing as we have just heard from the previous speaker about, ibrutinib, for example, and other novel biologics that we're increasingly using are having a havoc on our host immune system, altering our macrophage functions, T-cell immunosurveillance, and that leads to further risk of these opportunistic infections. And you could see in the ladder that we have here, the high risk has been traditionally the allogeneic transplant patients, AML, MDS, patients receiving induction chemotherapy, or patients with prolonged neutropenia, or receiving high-dose prolonged courses of steroids. But in the intermediate risk group, this is increasingly becoming more crowded, with ICU patients admitted with post-influenza, for example, becoming an increasingly a bigger risk. We talked about CLL and ibrutinib, and similar agents are proving more high risk for these patients. And then traditionally, this sort of diseases were low risk for infections, but now increasingly they are becoming intermediate risk category if you're treated with novel biologics. And then CAR T checkpoint inhibitors therapies are increasingly now being added to this sort of risk kind of time points where you are worried about the alteration in the immune surveillance again, and the lymphodepletion part of immunosuppression that comes with CAR T therapies, all leading up to higher risk of infections in these patients. Then going back onto a couple of those issues that I just mentioned, the respiratory viral illness, for example, patients who are admitted in intensive care units with severe illness, especially in the back of influenza A, for example, leads to quite significant higher incidence of fungal disease. For example, 19% patients who were admitted in ICU with influenza A developed fungal disease, compared to just 5% without influenza A. And that was much higher in the immunocompromised group of patients who were admitted in ICU with influenza A, reaching up to 32%, which is almost a third increase in the invasive fungal disease compared to the rest of the cohort they had in ICU. And that translated into higher 90-day mortality. About half of these patients who were admitted with influenza A actually died as a result of fungal disease, which went up to 70% in the immunocompromised group. And this was a very large study published in Lancet Respiratory a couple of years ago, which really drove in the risk problem with influenza A as a potential piggyback pathogen who can drive secondary fungal infections in these patients and lead to high mortality. And something that we are also now witnessing with COVID-19, for example, in the last 1 to 2 years, since this COVID-19 have wrecked everywhere in our hospitals, increasing ICU admissions, and then that leads to secondary fungal infections. And we published this work in terms of diagnostic algorithm, because we did see that signal in these patients in ICU, and kind of were quite concerned about lack of diagnostics, and often they present quite late post-ICU admission, and then contribute to significant mortality for these patients. It's something that needs to be considered in your care for these patients when you see them in ICU, for example. And then we published a diagnostic algorithm to try and help with that. The next question, really, we have to understand what other risk factors, patient-related factors, we may have to think about. And then we have been involved in a number of previous studies which has shown that baseline CT potentially is a predictive risk for developing fungal disease in these patients. And then when I mean baseline CT, it basically is a CT scan done just before commencing any form of induction chemotherapy or conditioning treatment for the allogeneic stem cell transplant treatment. And then we looked up recently, and just we presented that in our British Thoracic Society meeting just a couple of weeks ago, in which we showed a homogeneous population of 350 stem cell transplants were transplanted in our Center for Myeloid Malignancies. We could see there were high risk factors for developing abnormal baseline CT, which was noted in older patients with higher comorbidities, scores, pre-existing lung disease, or if there is a pre-existing history of invasive fungal disease in these patients, and they were more likely to have baseline abnormal CTs. And what that translated into a poor poor IFD-free survival in patients who had more classical ERTC defined changes at baseline. So if you have those changes, your IFD-free survival was significantly worse compared to patients who had either a normal CT or non-ERTC defined ERTC changes. And this led to, again, if you did have fungal disease developed post-transplant, there was a clear survival disadvantage for these patients. So really it comes down to that, what is there at baseline that we could have tried to improve? And this was a prospective study in which we looked at regular biomarker screening. We did bronchoscopy tests in all these patients, and then we could find out that clearly a subgroup of patients who are at higher risk potentially have to have much more increased interventions in terms of diagnostic work, and then regular monitoring post-transplant to try and reduce the risk of them developing fungal disease. So clearly an area where more work needs to be done to try and identify how interventions may change the risk profile. And then, back to this novel biologics risk, in which we just heard about talk on the ibrutinib and CLL, and I think it's important to highlight that the ibrutinib has been associated with increasing risk of opportunistic infections, mainly disseminated invasive fungal disease, even cryptococcosis type infection, CNS infections, and then primarily in the first 3 to 6 months of starting therapy. And that's been published case series wise, and there's some biological science work been also published since that suggests that there is alteration in the macrophage, alveolar macrophages, T cell dysfunction that leads to increases of these fungal disease in these particular patients. And then what about CAR T? Because that is the next question. We're seeing more of these CAR Ts in our center. We do a fair lot in the UK, and then our concern was that we're seeing increasing lymphodepletion related sort of viral infections, also fungal disease, but also there was long-term aplasia, which puts them at higher risk. These patients also get steroids, tocilizumab, for example, that puts them at a higher risk of developing these infections. And this early paper suggested there was definitely a signal of mold disease in these patients, and certainly in the UK NCCP data that we have certainly witnessed quite a few disseminated fungal disease presenting late post-CAR T infusion, roughly around day 20, day 30 sort of mark, when they are aplastic and often have a poor outcome associated with these infections. So we have started doing more early prophylaxis for these patients because of the underlying risk factors that currently in our group of patients. And this is where just kind of to mention recently published sort of phases of CAR T based infections, and you could see aspergillus infection do tend to occur not just early but a bit later in the CAR T therapy recovery phase. Around day 56 is the maximum sort of risk period, but PCP still is a concern in the longer term follow-up. In addition to the respiratory viruses and the other viruses that we sometimes see, we recently published HHV6 related encephalitis in a late onset presentation, which was certainly a rare presentation, but these things do happen. So all of these infections put a big risk for something to worry about in these patients. And then we have now all these neurotherapies that we're using for our patients in AML, ALLs, all the FLT3 inhibitors, BCL2 inhibitors, minor targets come back, inotuzumabs, and the CD20 antibodies. They all are now increasingly being available for our patients, and CAR Ts including. But the challenge really is how using these drugs and then other antifungals that we currently want to give them has a risk in terms of their interactions with these agents, not just in terms of toxicity profile, but also drug levels that are changed as a result of these interactions. And then you may treat some of these diseases because of poor drug levels of either the main drug or because of poor therapeutic efficacy of the antifungal drug if they were having a fungal infection. And that sort of interaction brings more challenges in terms of what's the right strategy to use antifungals for reducing the risk of them happening in these patients, especially in prophylaxis settings. And that again is need more data, and then more work is being done to try and identify how to best manage these infections and the risks for these patients. So in terms of a quick summary on the diagnostics where we are, and most centers will have easy access to culture and direct methods and microscopy type methods. It's just kind of standard minimum you could do, and if you're lucky, if you grow or they isolate in the culture, and then you could look through for hyphae, and then that's great, you could diagnose, but often that is a very late presentation. Often patients, if they're growing hyphae, by that stage it's already disseminated. So really more work is to be done in trying to identify them early at an early sort of angioinvasive phase, or even before they become angioinvasive. And this is where the antigen methods like lactomannan, beta-glucan, lateral flow devices, and then our work in glytoxin, for example, is showing some direction in terms of how we can screen these patients early and then treat if there is a signal of fungal disease. Similarly, PCRs are now become more streamlined and are now being advocated as of last year as one of the important tests to be included in new diagnostic algorithms for diagnosing fungal disease. And radiology, of course, is available in most centers, but that very much is a subjective technique, is limited by the operator's interpretation of the fungal infection. And if you're not have an expert or experienced radiologist in your center, then you may not necessarily be able to have a clear direction of if this is a fungal disease or not, and you have to rely on other test methods that I've just mentioned to try and help you in that direction. But at the same time, it's important to highlight that we do need also access to therapeutic drug monitoring with azoles, for example, because ultimately we would like to know if they are efficacious or not, if their area of the curve is definitely therapeutic or not. Because if you have a breakthrough infection, if they are under therapeutic, then you clearly know that this is an azole failure because of less or low drug levels, and you could probably switch to a more potent azole for treating them rather than switching class altogether. But if there is a good levels, then you may suggest this could be a resistance pathogens, and then may need to look for resistance screening using PCRs for these infections. And that can give you a clear idea of what sort of therapeutic modality you would like to choose based on these tests that you will have. And ERTC, as you may know, kind of got together back in 2002 to look for criteria to define fungal disease, and it was revised in 2008, and that has been mostly used in the clinical trials to look for efficacy of various drugs. And then it was again revised just about 8.5 ago in 2019, late 2019, which just before the pandemic, in which it recognized that there is an expanded group of host population. You have to have the right host to have a risk of fungal disease, and that includes prolonged neutropenia, all the mentions that I've just done about immunosuppressive drugs, BTK inhibitors, for example, and they all put you at risk of developing fungal disease. But you have to also have certain clinical radiological criteria matched to potentially call it as a possible fungal disease, for example. But more importantly, mycological tests that will hopefully give you better confidence in calling this as a probable fungal disease. Of course, if you can show the hyphae and grow and isolate, that's a proven disease. But more or less, we are stuck in the serological methods in most centers, or if you're lucky, a PCR-based method that you may be able to access. But that is patchy. Not everyone has access to these mycological tests, and turnaround times are an issue. So you're really left with a host and a radiological problem that you're trying to define if this is definitely a fungal disease or not. And this is where kind of it's important to understand that if you were to start waiting for applying ERTC defined criteria, in other words, trying to get all those diagnostics tests done, getting the reports through, by that time, the fungal burden has already kind of gone through more difficult phase, disseminated phase, which is much difficult to treat, and if you throw in targeted therapies, may not necessarily save your patient. So everything that is being done is trying to identify at an early stage, screening these patients before the burden of disease increases again is the key way to improve care for these patients. And I think combination of diagnostics could help in some way in that direction, because if you just use single tests, for example, in our center that was published a few years ago by Dr. Cisse et al., that only 11% patients, if you use a single test, for example, could be identified ante-mortem for potential fungal disease. But if you were to combine all of the tests, including lactomannan, beta-glucan, biopsies, CTs, PCRs, all that together almost doubled the incidence rate of these invasive fungal disease in the same patient group. And that was interesting because clearly we would have otherwise failed to identify patients in half of these patients if we just use one test. And because those patients were identified up to 21%, it is quite real life, because if you look at the postmortem series, around 20% of these patients are only diagnosed postmortem. And then clearly, by improving the combination and the better use of diagnostics, we should be able to detect them ante-mortem more early and hopefully reduce the mortality that otherwise is associated with these proven probable type diseases. And that is kind of what we really need to work on to try and improve diagnostics so that this curve is more flatter rather than kind of going south. And moving on to kind of from where we are in therapeutics, we all have basically 3 or 4 classes of drugs that are available to us, primarily 3 classes here, which is polyenes, azoles, and echinocandins, and we keep adding different drugs into these classes. More recently, for example, Icy Reconnaissal in the azole settings, and then enodulfungin, and even other drugs like fungin, for example, is coming along. But these are all just the same class of drugs, which are limited in choice, because if you fail one class of drug, you're left with two, and if you're intolerant with the other, then you're really left with one. And that really poses a big challenge in some of these complex infections, which are very difficult to treat for our patients. And it's important to highlight the spectrum of these agents against these pathogens. For example, Ambisome has a quite broad spectrum activity against most of the invasive fungal disease pathogens, including mucorales, including Fusarium, as well as Aspergillus infection, but also Candida infections. If you look at the Candidans group, for example, it's mainly limited to the Candida group of pathogens, and less so for Aspergillus or any other of the rare pathogens. Azoles, mainly the triazoles, seems to be doing quite better in terms of the overall spectrum of cover, mainly with posa and Icy Reconnaissal, and voriconazole has a limited effect on the mucorales, which is its limitation. So it's important to kind of know how the spectrum of cover for each of these agents before we start thinking about how we're going to use one of these drugs for our patients. And it's important to define the strategy you would probably want to take in your center, because you need to know what your epidemiology is in your center. If you're really seeing high-risk patients, you're doing allogeneic CAR T, allogeneic treatments, CAR T patients, all of that will define if you are seeing a high-risk population that you may need to think about prophylaxis or empirical approaches. If you're not seeing as many high-risk or just lower intermediate risk patients, you may get away with using preemptive approaches, but you have to have diagnostics in the middle of it to try and give you that chance to be able to do preemptive approaches. Otherwise, you're stuck with either giving a large amount of prophylaxis to a bulk of large patients, and then an empirical approach for fever-driven strategies. And that is not really ideal, because we often overuse these agents, and that means more toxicity, more morbidity for these patients from a treatment point of view. And that is what the key part is where antifungal stewardship starts coming in, is how we improve that element and move towards some sort of preemptive or focused treatment for these patients using diagnostics. And if you talk about empirical approaches, for example, and a lot of previous studies back in the 80s and going to early 2000s were published looking at different drug models, including conventional Amphotericin B, fluconazoles, conventional versus liposomal formulation. And then the one I would like to highlight was the key one that was heavily talked about at the time, with the comparison of voriconazole versus liposomal formulation of Ambisome. And then this was a randomized study, and that came back showing some equivalence in the composite endpoints and with variable success in the secondary analysis. Again, this was a questionable study, and I'll show you a little bit why. Because if you look at this sort of table, most of the responses were in favor of liposomal formulation, except the one which is in the second row here, which shows breakthrough infection, was lesser in the voriconazole arm. However, this study failed to meet the defined endpoints. As I said, Ambisome appeared to be superior to voriconazole on all the other endpoints. And even this breakthrough infection, where this voriconazole was shown to be a bit better, was also misquoted according to a later critique published by FDA and Cochrane Review that clearly criticized the study design and how definitions were used for breakthrough infections, definition for voriconazole arm, for example. And that seems to be suggesting that this may not be a correct interpretation of how the efficacy is of voriconazole versus liposomal formulation. And if you look at within the amphotericin formulations with liposomal versus conventional arm, it clearly, on the Cochrane sort of meta-analysis review, and we all know from our experience, that liposomal formulation is better tolerated, has less toxicity issues with renal toxicity, for example, and that leads to potentially reduced invasive fungal disease related morbidity with these patients. And that's probably because they are better tolerated and are able to have it for longer compared to the conventional drug, which is often difficult to give, and then they often have to discontinue early on and may not have the desired effect. And if you look at the doses, there's a clear signal that the 10 milligram dose, for example, is not really needed. You really don't add any benefit by using higher doses. 3 milligram per kilogram dose is generally quite good and tends to give you significant similar responses compared to a 10 milligram dose, and you try and avoid toxicity by doing that. But if you look at the empirical approaches, when you compare with the liposomal formulation of amphotericin with caspofungin. And this was done again about 16, 17 years ago now. And this was the only randomized study at the time which compared these two drugs and looked at a large population of 1,100 neutropenic patients post-chemotherapy, for example, and some stem cell transplants. And it definitely showed that there was efficacy for caspofungin with a similar overall response. But if you look in the details, most of the patients included into this study from our current definition were low-risk patients. And then clearly suggesting that you may not necessarily could compare the efficacy of caspofungin with the liposomal formulation in the high-risk settings. And this is where IDSA and even subsequently ECIL guidelines have suggested that echinocandins are not effective in the first line or monotherapy of invasive aspergillosis, but can be used as a salvage therapy. And then again, where azole and choline antifungals are contraindicated. So clearly, as a second line, it potentially has a role, but not in the first line settings. And if you look at empirical versus preemptive approaches, and this was again a defining study where people felt more comfortable using empirical approaches because it could clearly show that there was a decrease in risk of fungal disease if you were to use an empirical approach versus a preemptive approach. Although you could, preemptive approach definitely had a reduced antifungal use, you were saving some money, reducing from the fungal use, but it led to more morbidity because of more patients were actually developing fungal disease. And this was done in the era when diagnostics were really not well done. And I think things probably are improving since with better use of diagnostics, and have to rethink this strategy about, just bound or sort of fever-driven strategy from empirical approaches, moving on to some more of preemptive or screening, targeted screening strategy where we can kind of use these antifungals in a bit more judicious manner. And if you look at the treatment elements where patients were treated with proven disease, and this is where voriconazole was successfully able to show that in this randomized study, when they compared to conventional amphotericin B, not the liposomal formulation, conventional amphotericin B, showing a superior survival benefit if you use voriconazole in treating these probable proven disease. However, this again study published about 18, 20 years now has been criticized since multiple times in various reviews, as well as Cochrane review, which looked at the detail of the devil really, because the authors handicapped the amphotericin arm in this study by saying that if you were to develop renal toxicity or electrolyte imbalance, you would come off this arm altogether. And that meant only median of 10 days of therapy was given for amphotericin group versus 77 days for voriconazole group. And as you know, the more you can give for a longer period of time, you're likely to have a better outcome for these patients. So maybe for that reason, the voriconazole did manage to show better survival, and amphotericin B patients could not successfully treat fungal disease and then had a poor survival. And this is what seems to be the issue when we start thinking about how voriconazole efficacy is when you compare to amphotericins. But again, this is not compared directly to liposomal formulation, and there is no study ever since been published in a randomized fashion for that. If you look at Icy Reconnaissal, which is the new kid in the block, it's a triazole and seems to be quite effective in treating probable proven fungal disease. And it was shown in the SECURE study published a couple of years ago that had non-inferiority to the voriconazole arm, suggesting that it works equally well. And on the plus side, it does not need any therapeutic drug monitoring, which was highlighted by the company at the time. But there are definitely some areas where the therapeutic drug monitoring could be used for these patients with isavuconazole, and that led to ECIL 6 grading it for 1A as a treatment option for patients who have a probable proven disease. And then more recently, just hot off the press, this study was published just last month in Lancet, and this compared posaconazole versus voriconazole in the treatment setting, again, phase 3 study, randomized controlled non-inferiority trial, and it also showed that posaconazole was non-inferior to voriconazole and was better tolerated, as much reduced significant toxicity profile, really suggesting that possibly the days of voriconazole are slowly becoming, over, and we do have better drugs in the azole group of the class of antifungals, where we can successfully treat these patients with limited toxicity. And that's something we have to try and think about in our equation of our patients when we think about the algorithm for treating these infections. And then that lets kind of just overall summary of where we are in the therapeutic drug options. we really have the choice between the conventional amphotericin B or liposomal formulations, voriconazole, posaconazole, isoconazole, or echinocandins. But this is all just based on number of 5 studies that was done as randomized study, and only the more recent one, which I just highlighted, published a month ago. But all the other studies have, been very limited in terms of defining one drug efficacy over the other, and the liposomal formulation has not been really studied in that manner when we compare to the other agents that are currently available. So it's important to think about where do we fit in with these agents in the overall algorithm, because you need to see what your risk profile of your patients are, what sort of diseases you are seeing, resistance in your hospital for azole resistance, for example, toxicity issues, cost, of course, is an important part of that. Can you access these drugs? And all that has to kind of take into account when you start building up your algorithm and define first line, second lines for use of these drugs. And ECIL gives you recommendation for proven probable disease with voriconazole, which again is a flawed study, but been given A1 grading. Isoconazole on the secure study been given A1 grading. Liposomal formulation is sitting at B1 grading, and based on more retrospective series data rather than a randomized study. So clearly that is a missing gap that hopefully needs to be sorted to look at the true efficacy of the liposomal formulation. And in terms of kinetics,
1 minute, please.
Yeah, micafungin is any of the kinetics are similar in efficacy. You can use either of these agents. It doesn't have any better than the others. And in timeline of the antifungal drugs, we are lucky we've got more drugs coming along in the last decade or so, but increasingly the resistance is increasingly being defined for these agents, mainly because widespread use of these drugs in agriculture, environmental sort of, or industries where these drugs are being used, and leads to more widespread resistance. We are lucky that we are now becoming available some new class of drugs, which is what I mentioned here, risafungin, for example, orotamide inhibitors, and fosmanogenipics. I'm quite excited about the fosmanogenipics because it has a broad spectrum of activity, but orotamide, it can be quite useful in azole-resistant type complex infections, and we're doing studies on these drugs in our center. And it's important just finally to mention that all of that is quite good, that we try and getting a better in understanding the type of fungal disease we are facing, the drugs effect from the immunobiologics we're giving on the type of patients we have, but we also have to understand the cost and the resistance of these infections. That will also be a problem for our patients. And this is the resistance map that we can see in the red here, where the resistance is being defined for azole, for example, but the white is where we don't have the data yet. So clearly there is a increasing azole resistance. This was published 2016, 5 years ago. So we certainly have a lot to work for to improve care for these patients. And then finally, just a slide to show our algorithm for our fungal disease management in our patients. We do twice weekly screening for galactomannan. We do baseline CT in our patients for all high-risk categories. If they are febrile persistently, we do drug levels, as well as we request a CT chest. We look for signs of fungal disease in ERTC defined criteria. If they have, we give them ambisome as a class switch, because we use posaconazole as a prophylaxis. So we switch from azole to a polyene in this setting. With the non-specific infiltrates, we request a bronchoscopy, try and define a pathology, and treat in the meantime until we have one way or the other an answer for possible fungal disease or not. If they have no infiltrates and negative biomarkers, then we don't treat and we continue with the prophylaxis model. Of course, if they have a positive biomarkers but negative CT, we may still treat it for a week, but repeat it a week later and then define if we can stop it. So that's kind of how we try and follow as an antifungal stewardship in our center to try and reduce use of antifungal drugs for non-fungal indications. But there is such more work to do to try and improve diagnostics, which hopefully will change how we treat these patients. And with that, I will stop and take questions. Thank you.
Thank you, Dr. Mehran, for an elegant talk. So now we'll have a few questions due to the time. So the first question I have is, an immunocompromised patient, like bone marrow transplant patient, for how long you would give a maintenance antifungal? Yeah.
You mean prophylaxis antifungal?
For those who are immunocompromised. Yeah.
Yeah.
So if you have a patient who had a confirmed invasive fungal infection and they are still using an GVHD prophylaxis, for how long you will give them? Of course, prophylaxis.
Yeah. So one, of course, if you have a defined objective for the risk period, really. So if you can define what your risk period is, if it's neutropenia, if neutrophils are, for example, more than 0.5 and 2 subsequent readings, we tend to stop prophylaxis and go down to fluconazole, for another few weeks until their lymphocyte counts to recover. If they are on immunosuppression, let's say cyclosporin had T depletion as part of their conditioning for transplants, we tend to again use triazoles until the neutrophils have recovered, but then just use fluconazole, for example, up to 3 months. If they have GVHD and they're on steroids or immunosuppression treatment, then we give them posaconazole, because that's where the data is strongest at for using triazoles for prophylaxis model until the GVHD is well controlled and come off the steroids. And that's when we stop the azole prophylaxis and change to fluconazole again. It's just defining the high risk period for that patient group that you need to treat, and then stop maintenance as that period is over.
Thank you so much. Other question is, before bone marrow transplant, if a patient got discovered with a fungal infection, for how long would you delay the transplant?
Very good question. I think that is something we always have in the back of our minds, because this is where the baseline CT and the risk assessment that we do for our patients. We also have been looking at using Bologna score, for example, to define if they have a previous fungal disease history. Do they have active lung disease of any other kind? Are they significantly neutropenic at the time when they're going for transplant? All that suggests that if you do have a fungal disease, then you would definitely want to consider treating that, and obviously get a diagnostics done by bronchoscopy to understand what sort of bug that might have, if it's Aspergillus or Candida or Fusarium, for example. But delaying transplant very much depends on the risk of the underlying disease and the need for neutrophils. And if you think patients do need healthy neutrophils back in to get through this fungal disease, and there is a high risk of the underlying disease to relapse in the meantime, then we tend to just go ahead with the transplant with use of most effective agent that we have at the time, which usually is a polyene, but sometimes we do also add in a second antifungal, either an azole-based combination for that high-risk period when they are really sick, until neutrophils have recovered, and then we step down to a single agent and then come off to a prophylaxis. But those are the kind of risk areas we have to think about, because as I showed in my study earlier, that they have a very poor survival if they do develop fungal disease post-transplant and they overall don't do well. So if we can try and optimize them before going in, and if there is a time to do that, great. If not, it is potentially a risk benefit in terms of waiting or not, and then maybe dual antifungal approach in these patients may help. Sometimes using granulocytes can be helpful to try and reduce the amount of invasive fungal disease. They have a aspergilloma, for example, but there is again a balance in terms of the risk of HLA sensitization, risk of potential GVHD flare post-transplant. All of that has to be kept in mind. So we try and treat as much as we can before we go in. That's the answer, really.
Thank you so much, Mehra. By this, I would like to conclude day 3 of the annual Saudi Hematology Congress. Special appreciation to all the speakers, as well as the moderators, the organizing committee, the technical team, and at the end, special thanks to the 4,000 attendees who are still with us until now. So stay safe and see you tomorrow.
Thank you. Great.